I'm David Lombardo, and this is WCNY's The Capitol Press Room. For more than 5 years, Democratic state lawmakers have been kicking around a bill that would require healthcare providers get informed consent before testing pregnant or postpartum women and their newborns for the presence of alcohol or drugs. To discuss the status quo and why it should change, we're joined in the studio by Dr. Erinma Ukoha, an OB-GYN and maternal fetal medicine specialist for New York City Hospital. Thanks for making the time, doctor.
Thanks for having me.
So, can you elaborate on the drug and alcohol testing of pregnant or postpartum women and their newborns, which you're looking to change? For example, how is this done right now without a person's informed consent, and what is the information being used for?
Right. I think that's a great question, just to kind of lay the background about why this bill is so important. So nowadays, depending on where you go to deliver or where you get your prenatal care, and depending on what you look like, people can take a urine sample and send that for substance use screening. And often that can be done without consent. Right? When people are admitted for labor and delivery, there's a lot going on. I'm sure, as you all can imagine. There's pain, there's people coming in and out, there's procedures that are being done. And sometimes during that hospitalization, a urine sample is taken without anyone asking, and telling that individual specifically what it's going to be used for. And that's sent for urine toxicology testing, so substance use testing. And those results are being used, whether they're preliminary results, whether they're accurate or not. Those results are then being reported to the family policing system if they are positive for any substances. And that information can be used to separate families unjustly. And that's the practice that's known as test and report. Doing that test, that's often non-consensual, and then reporting to family policing system and all the subsequent downstream effects and harm that leads to those individuals.
You mentioned the idea of what you look like. Does that mean there are disproportionate practices based on race and ethnicity?
Definitely. There's disparities that we see and there's data that supports that Black women are more likely to get tested. And not only are they more likely to be tested, but they're also more likely to be reported. And then within the family policing system, Black families are more likely to be separated. So just this one test that happens on labor and delivery that often people don't know what's going on, or there's not a conversation or discussion about that, can lead to all these downstream consequences that really have an impact on people's lives negatively.
Well, you say downstream consequences, you say negative ramifications, but is there a interest in society of getting this information to the relevant stakeholders? Is there an interest, if someone is testing positive for drugs or alcohol, to make that information known? I mean, what do you see as the downside versus, I guess, the potential upside?
Right. I think that's a great question because, one, anything that we do medically, there should be a reason for it, and it should be to help an individual. Right, and when we think about substance use, a drug test is not a parenting test. It doesn't tell us about anyone's qualifications or ability to take care of a newborn or the children that they have at home. There's a lot of bias that goes into us about how we feel about pregnant individuals that use substances, and how we feel about poor people and that use substances and are pregnant, and how we feel about Black and brown people who use substances and are pregnant. And that all comes into play in when a test is done, especially when it's not clinically indicated. Right, so the goal of any substance use screening or testing that we do should be to connect people to care, to make sure people get any substance use treatment care that they need, access to prenatal care, things that are going to make them healthier, that are going to give them better outcomes, give their newborns better outcomes as well. And so when we do this testing, informed consent is at the basis of all of that. It's building trust, it's building transparency, it's making sure that the goals of care are aligned with that individual's goals and where they're at. So there's no reason that the testing should be done without informed consent if we're saying the goal is to get people the treatment, the care that they need in order to make sure that help people have healthier and better outcomes.
Well, then let's turn to the legislation that has been kicking around the legislature for a couple of years now. What is the standard for so-called informed consent that would be required as part of this bill if it became law?
Right. This bill is asking for informed consent before substance use screening or testing, so either a verbal screening or urine toxicology testing, and that consent should be both verbal and written consent. So it's all about making sure people understand what's happening with them, are participating in their care, and are leading that care, and we're ensuring reproductive justice and bodily autonomy. So it's definitely an important step, and it's a small step, and it's a needed step as we go to address the disparities that we see in care.
Well, speaking just for myself, my own interactions with the healthcare system, I have definitely signed off on paperwork or tests without necessarily having a good idea of how the information was being used or what it would cost me for that matter. But what does informed consent mean when you're talking about, say, going through something like this screening? Because do you have to spell out what the potential ramifications of this test are so that someone is actually making an informed decision?
Right. It's about talking about the ramifications. It's about talking about the indications as well, right? Explaining why we're doing a test, what that information, why it's important, how it's going to change your care, and what that information is going to be used for. And I think that those are all pieces of informed consent in any testing that we do, and should be part of, conversations about why we're doing screening, whether it's for substance use or for HIV testing. There's implications, genetic testing as well. There's implications, there's ramifications, and people should understand that before agreeing to participate in something.
Well, before we move on, let me reintroduce you. For listeners just joining us, I'm David Lombardo, and this is WCNY's The Capitol Press Room, and we're speaking with Dr. Erinma Ukoha, an OB-GYN and maternal fetal medicine specialist. So you've talked about how this information could be used in a negative way, but would you still be supportive of this information being collected if it was only going to be used for medicinal purposes or to support and help that mother and potentially the newborn child?
Right, and I think the bill does allow for substance use screening and testing. It's just the manner in which we collect that information. I think from a medical standpoint, there's very few times where a drug test in the moment changes clinical decision making. Just speaking from experience in the care that I give to people, one, conversations are much more telling than in a drug test that's open to misinterpretation, open to false positives and such. And critically speaking, in an emergency situation, no one is waiting for a drug test before, going into action and treating people. And so I think there are few and far between situations where a drug test is medically indicated. And if that situation does arise, then this bill is just saying, let's have a conversation. Let's make sure an individual is involved with that decision. And people want what's best for their care. They want what's best for their babies as well. And so we're just making sure that they have an opportunity to participate in that conversation.
Well, you say someone wants what's best for their children, but if someone has, say, a substance abuse problem, I mean, this is a medical condition. They might want the best for their kids, but maybe they're not going to be in a position to provide what's best. And when they are now presented under this bill with that informed consent decision and they are told, well, if you do test positive for XYZ, this might lead you down this road, maybe they're going to decline that test. So are there negative consequences that we might be opening the door to by limiting these tests?
Right. And individuals with substance use disorders, people, right, I think there's a lot of bias that goes behind that we have in general as a nation against individuals who use substances or people who have substance use disorders. And I think it's well within anyone's right to decline a test, right? If they decide that they don't want any urine drug test or don't want to participate in that conversation, our goal is to meet people where they're at and to help them get to where they want to be. And so if someone's not interested in substance use treatment, it doesn't change the care that they're providing for that newborn. It doesn't change the care from a medical standpoint, which people are providing from the newborn or for that individual either, right? We're there to treat their symptoms, to treat what people are coming to us with. And the data supports that there's no, New York Health and Hospitals just changed their policy regarding substance use screening and testing, and it showed a reduction in tests. Especially for Black patients, it showed an 80% reduction in reports overall, 90% reduction in Black individuals, with no difference in newborn outcomes, no difference in care. Right? So we're talking about keeping people safe, keeping people connected to care, and creating an environment where people can continue to engage in care and can continue to come back and when they're ready and be connected and supported.
So again, this is going to show my novice as a childless adult, but if someone, say, is using an illicit substance and they're a new parent, and let's say they're going to be nursing, for example, is that something that can have negative repercussions for the child?
It depends on the substance. It depends on what's going on. We know that in babies that are born with neonatal abstinence syndrome, that the treatment is eat, sleep, and console. Right, and so that means it's just treating the baby like a baby, and what it needs is care, It needs to be consoled, it needs rest, and it needs to continue to eat and breastfeed, whether it's breast or bottle feed. But that is our standard treatment for substance use disorders for babies that are born with neonatal, specifically opioid withdrawal. And so that's what we're putting into practice. And we don't need a drug test to tell us to keep the family together, have the baby keep eating, have the baby keep sleeping, and consoling.
So as you and fellow advocates make the rounds for this bill here at the Capitol, what sort of questions or concerns are you hearing from state lawmakers, and how familiar do you think they are with the maternal process? Do they have more knowledge than me, hopefully?
I think a lot of the same questions are coming up. I think there's some misinformation, there's some disinformation about what the bill does and does not do. I think there's bias that we have to address about people who use substances in pregnancy, about people who use substances in parent. I think we're here to prevent counter narrative. There's a lot of impacted people with lived experience here sharing their stories that I think are very powerful, very moving stories, and just the experience they had and how it affected them and how it altered how they engage in care. And so I think we're here just to spread information, spread truth, and really get this bill signed and passed into legislation this year.
If the bill does become law, do healthcare providers need additional training on how to go about getting informed consent or having the conversations with their patients about maybe why they should submit to this without being maybe coercive?
I think informed consent is really at the crux of medical education and medical ethics. So the practice of it isn't anything that we're strangers to.
But although right now, though, you said people are doing this without informed consent, so
exactly.
It would definitely be a change for some people.
It definitely will be, and I think the biggest thing is that it's going to address the underlying racism and bias in which people decide who to test based off of their race and ethnicity, their socioeconomic status, and it's going to force people to have conversations about why the clinical indication behind a drug test and what the implications are. So I think there's going to be a lot of dissemination of the law, what it's requiring and what that looks like. But I think like from a day-to-day basis, at least in how I practice and in how a lot of providers practice, not much shouldn't be changing from the informed consent that we know how to do. It's just the choice of actually doing it in the right way.
So you don't think there needs to be some sort of accountability or policing measure for those healthcare providers who have gotten used to the practice of just, hey, I'm going to take this urine and I'm going to send it here because I know best and I think this is the way we need to do things? I mean, do we need to look over their shoulder if this bill became law?
I think there has to be some sort of accountability measure, collecting data about who is tested and what numbers are tested, and reflecting on if informed consent was done and having accountability in that process, and also collecting data about who's reported to ACS and family policing and what that looks like, just so that we can show the benefit the same as New York City Health and Hospitals did. I think collecting that data and those numbers are going to be important, and one, making sure this legislation is put into practice as it should be, and then two, showing patients that things are changing for the better.
Well, we've been speaking with Dr. Erinma Ukoha. They're an OB-GYN and maternal fetal medicine specialist. Doctor, thank you so much for making the time.
Thank you for having me. I appreciate it.
Thanks for listening to today's edition of the Capitol Press Room. For an insider take on what's happening in state government, check out our Dispatches from Planet Albany show, available wherever you get podcasts or at capitolpressroom.org.
Join us again for Capitol Press Room, a production of WCNY Connected, Syracuse.